Well, welcome everyone to this week's HPL seminar. Today we'll be hearing from Matt Jordan. Matt is currently an assistant professor here in the Faculty of Kinesiology and Sport Medicine at the University of Calgary, working in the Integrative Neuromuscular Strength and Power Lab. He has also worked as an adjunct professor at Edith Cowan University and as a sports science advisor at Canadian Sport Institute, Calgary. Matt's research interests include neuromuscular adaptations to resistance training with a focus on prevention of traumatic knee injuries in athletes. Matt's proudest accomplishment is having a budding research program dedicated to studying the factors to support the return to play after ACL injury. His future goals are to develop data-informed models to forecast recovery, along with targeted rehabilitation and training methodologies that address the neuromuscular comorbidities that arise consequent to traumatic knee injuries. A fun fact about Matt is, despite working with alpine skiers for more than 2 decades, he is not a very good skier himself, and he was banned from skiing on an Olympic downhill course after barely surviving his only descent on Russian rental skis. However, after spending several months traveling with the Canadian cross-country ski team, he thinks he is mastering that art. As a reminder, I will first turn it over to Matt for his presentation, and then we will have a question and answer period to follow. So thanks, Matt. You can start sharing your screen.
Great. Hey, great. Appreciate it. I'll just do a quick radio check. Are we good?
Great.
Excellent. Okay, so planning about 45 minutes here, and I want to, I guess, a couple of different objectives. The first is to give an update of where our research program is at, and to share some data from recent publications. We're calling this, well, I started calling it, much to the dismay of some of the people in our research group, I called it the When Am I Ready project, and no am is not a typo. I got accused of that being a dad joke. You'll see as we move forward what the AM stands for. I just want to briefly acknowledge the many individuals who've been a part of the work I'm sharing here today. Colleagues, graduate students, collaborators, couldn't do this without them. Briefly, you know, as Emily stated in the opening, my research program is around how the neuromuscular system adapts to resistance training, but special focus is on traumatic knee injury. And but kind of fit it into 3 things: trying to address the need for better tests and diagnostics to measure deficits in athletes with ACL injury, to be able to use these data to inform sort of recovery timelines, and last, obviously, to work towards better rehabilitation and retraining techniques. And today I'm going to talk a lot about the counter movement jump, which you see in the video here. There's a video of the same athlete. One is her about 4.5 months after her ACL reconstruction, and one at 7.5 months. And we use this technique of performing a jump on a double force plate system, where we can look at the biomechanics of the jump, and we can use these tests to quantify recovery after ACL injury. So just briefly, I want to sort of scope the project here today, because it actually goes all the way back to 2010, when I started working with the women's alpine team after the Vancouver Olympics. A bit, so want to acknowledge, all the help from Walter and Azim and Per Agard, who were just so fundamental in helping me get my feet off the ground in this space. And then as the time has gone on, this program has grown from, what was a PhD project to a program at the Canadian Sport Institute, Calgary, that's been supported by many people in our Strength and Power Lab, graduate students. And we now have a program that's called the R2P Code, which is basically a program that's bringing research and service and practice to athletes who've suffered ACL injury. And that's led by Isabel Aldrich-Witt, who's on the far right here, who is a physiotherapist and also a graduate student who's really leading the charge now and sort of like delivering the service to all of our athletes. And in 2022 and beyond, I just want to talk about, just quickly, that great collaboration with Kati Passanen, who over the years has become, a person that worked on several projects with. And we're working together to establish sort of a combined approach to bringing our testing methods to the University of Calgary and to the Faculty of Kinesiology. And both programs will coexist moving forward as I delve into or head into the future. So just a quick anchoring point for today's presentation. I want to talk about 4 stopping points. A lot of this will relate to alpine ski racers, but I want to talk about the importance of addressing this topic around of ACL injury in that population. Talk a bit about our data around secondary ACL injury prevention and how we are using a data-informed approach to move from the N=1 level, so sort of the case study of an athlete who might be sitting in front of us who has an injury, all the way up to this longitudinal study that's been going on now for almost 10 years to be able to develop these data-informed models of recovery after injury. So first of all, why this matters. I think it's safe to say that an ACL injury is potentially one of the biggest threats to an athlete career, whether you're a ski racer or a football player or soccer player. The statistics are pretty grim. In field sports, a little more than half will make it back to their pre-injury performance level. Alpine skiers seem to fare much better in terms of getting back to their pre-injury performance level compared to other sports, but these injuries are devastating. You can imagine in a ski racer, it's the same as what you might see in a motor vehicle accident on a highway. Very high energy injury mechanisms, and of course that leads to a lot of injury to the knee joint. The epidemiology in alpine ski racing paints the picture. The knee is the most commonly injured body part, and an ACL rupture is the most specific and frequent diagnosis. Interestingly, no difference between males and females at the elite level. That does change in more development level ages, so sort of adolescent age. But at the top level in the sport, we don't see the sex differences that sometimes appear in field sports. Some of the research that we've done over the past 10 years has been to go and really understand the nature of ACL injury in this population. And this was a study that we published in 2017, where we'd gone back and looked at operative reports from athletes who'd suffered ACL injury. So we partnered up with our orthopedic surgeon team, and we went through and basically looked at the types of ACL injuries that these athletes were sustaining, and specifically what other types of injuries did they have? Injuries to the menisci, to the cartilage, multi-ligament injury. And what I can say is that, based on this project, is that it's not just an ACL injury. Rehabilitation here is measured in months, if not many years, as you'll see throughout the presentation. 32% sustain multi-ligament injuries, 54% have severe chondral injuries, and many of the injuries here that we see are consistent with what you might see in a very sort of high-speed motor vehicle accident, actually, in terms of the severity of the injury itself. But probably more kind of grim is that in this study, we were able to obtain operative reports and look at how athletes fared after that ACL reconstruction surgery. And specifically, we were looking at the occurrence of re-injuries, contralateral knee injuries, and then at these future states when we would obtain these operative reports. So you had your ACL reconstructed, but then you go back for a scope. What was the progression in terms of the knee joint health? And what we found was that about 30% of our athletes were suffering a re-injury, which is consistent with the literature. And when we looked at the future state of the cartilage of the knee joint, 80% had demonstrated a worsening of their chondral injuries from that primary ACL injury and that index surgery that would have occurred first. So, I guess this kind of leads you to the next part of the story is, when somebody suffers these injuries, they occur frequently. We know that the attrition rate is pretty severe after an ACL injury in terms of the likelihood of a re-injury and the potential progression of the injury itself. And inevitably, the question that comes up is, hey, when am I going to be ready to get back to sport? And, virtually everybody's asking this question, the coach, the athlete, the parent, the physician, the strength coach, the physical therapist. And I want to just highlight in on this athlete here that you see, you may notice it's a pretty gruesome looking fall. But what's occurred here is he's a left side ACL re-injury, and he's now probably, about after a year after his injury. And you see him coming around a turn, suffering a fall, and you see him now clutching the contralateral knee. So he's just become one of these statistics of a contralateral knee injury subsequent to that first ACL injury. And this is something that is obviously front in mind for all practitioners who are working with the sport. There's no question, the Holy Grail, in search of the Holy Grail, have a genie in a bottle and I can identify from a group of athletes who might be at greater risk than another for an injury. And obviously these predictive models are what we're chasing. And that's why we're doing this sort of expansive long-term injury surveillance and neuromuscular testing, is to really develop these predictive models for primary injury prevention, which is where Dr. Passanen's research is focused. Secondary injury prevention, which is the prevention of that second injury, and then tertiary prevention of injury prevention, which is really mitigating the long-term effects of the injury. To have these sort of models that could allow us to identify athletes from a group who might be at risk. And then importantly, to address this issue that, the attrition, as I've said, like many athletes aren't making it back to their pre-injury performance level, to have some predictive models that could help us inform decision-making and help us characterize how these athletes are progressing over time after their injury to support this return to pre-injury performance. That's obviously, the holy grail that we're all chasing. But in addition to those, I would say it's a relatively big goal of prediction. What we're also interested in is answering some other fundamental questions. And these seem to be the ones that often arise in a clinical environment or in a sport performance environment, are questions like, when will they be ready to go back? What's the recovery timeline based on the surgical technique that may have been employed? If it was a severe injury, how much longer will it take them to get back? And then, really at the level of how practitioners are working with athletes who've suffered injuries, it's being able to kind of identify what might be lagging in terms of their neuromuscular deficits, so that we can target that with training and use our training approaches and rehabilitation to address a lagging neuromuscular capacity. And lastly is being able to identify, as athletes are recovering, whether or not they're progressing towards or regressing away from their goals, which, as you'll see in this presentation, is pretty key. So as we transition here, I just want to say, there obviously prediction is the thing that we would love, but let's just say that there are lots of other really important questions that data can help us answer, and I'm going to hopefully be able to show you some of them here today in the presentation. So our second stopping point is looking at how we currently address this attrition, right? So the fact that athletes who've suffered that first ACL injury are at 14 times greater risk than a non-injured athlete of suffering a second ACL injury. So, the risk profile really does change after that first injury. And that's why, obviously, it's one of the key things that we're trying to address throughout this process after an ACL injury. But you might be surprised to know that when we look at the science on this, it's been shown that despite knowing that we should be measuring objectively neuromuscular function, a high fraction of practitioners have been shown to rely simply on time as their main criteria for when an athlete's ready to get back to sport after an ACL injury. So, this would be a standard answer that you might get. It's 9 months, it's 10 months, it seems to vary a little bit. But what we know is that how time unfolds and how your neuromuscular function unfolds, they may not occur at the same rate. And really, the idea that, we're potentially just using time as our only marker is definitely problematic. A second thing that I would say is a bit of an issue around addressing these issues, and again, another potential thing that you may be unaware of, is that very often in a clinical environment or in a practitioner environment, we're simply just using our eye to evaluate neuromuscular function and control in sort of standard performance tests. So you do a jump or you do a drop landing, and maybe we're looking at this quote unquote kissing knee phenomenon, where you sort of have that frontal plane translation of the knee. Sometimes we call that knee valgus. And I just want to highlight this study. It's kind of an interesting one that was published recently, where they showed videos of handball players to a variety of athletes to various forms of practitioners, from physical therapists to coaches to athletic trainers to physicians. And they showed these videos of athletes performing a drop jump, and they said, can you predict who will go on to suffer an ACL injury? And so based on the video, the practitioners would say, well, this person's going to be at risk and this person's fine. And what was very interesting with this study is that, and you can see here the area under the curve for each of the occupations is that it was no better than chance, which kind of reinforces this message that time and or eye are simply not enough. To make matters a little bit worse, another form of testing that we often use are these hop tests. So, maybe a triple hop or a single leg hop for distance. And sometimes I call these performance-based tests. And then what we'll do is we'll compare the injured side to the non-injured side, and we'll have a threshold. We'll say that, you should be within 90% of your non-injured limb or 85% of your non-injured limb to be cleared to go back to sport. And these benchmarks are relatively arbitrary, actually. There's not a lot of good evidence to support why we use them. Another thing that you may note is that in a lot of the standard test batteries in the clinical environment, they typically use testing in the same movement plane. And they're also not usually measuring biomechanics. So it's usually a tape measure on the ground. And are you jumping, whatever, half a meter on your left compared to half a meter on your right? That would be sort of the outcome measure that is readily obtained. And I just want to highlight this, and I didn't pull this data into the presentation just due to time, but a recent meta-analysis found that athletes who passed criteria according to these conventional tests, like the one you're seeing in the video, while it was a sort of a statistically significant reduction in the risk of re-rupture of that same knee, the risk of contralateral knee injury actually went up more than 200%. And so what I'm saying here is that the individuals who passed criteria, it was actually associated with a relatively substantial risk of a contralateral knee injury after that first ACL injury. So that's led us to say, hey, some of this evidence in terms of how we currently address secondary ACL injury prevention is sort of, there's room for improvement. A recent study that now sort of paves the way to what I'm going to talk about here today is to use biomechanical testing. And this was a nice study that was done by a group in Ireland. They had more than 1,400 level 1 athletes in Ireland, so quite high level athletes in a very controlled environment, very impressive setup actually in terms of what they did in terms of their testing. But they brought these athletes in after their ACL injury, and they tracked them using not only your standard clinical test that I showed in the previous slide, but they actually measured some biomechanics. So they did some drop jumping, some change of direction tests. And it was really interesting to note that the biomechanical testing seemed absolutely key, because when they looked at the clinical testing and a lot of our standard assessment techniques like hops for distance and simply measuring performance, they found that there was little association with a future risk of an ACL re-injury. And what I just want to sort of, as we start to pivot here in the presentation, I want to introduce this idea of jumping as a great test that when we measure the biomechanics of a jumping human, that it now becomes potentially a good test for us to look at the ACL injured athlete towards ACL re-injury prevention. And in this study, what they found was that while the traditional tests weren't predictive of a future risk of an ACL re-injury, that athletes who were displaying, sometimes I say it, they were more like a squishy Cadillac compared to a suspension of an Audi S4. And they tested this in the drop jump, like you're seeing in the still shot, the cartoon on the right. They actually found that the athletes that were represented here by this more darkened silhouette, they actually displayed reduced, I would call it whole body stiffness. And I'm not talking about material stiffness. I'm talking about the relative change of force and displacement of the body center of mass, that they displayed less of it compared to the athletes that fared well, which is shown in the faded silhouette. So this sort of idea that plyometric ability, or what we call stretch shortened cycle capacity, is predictive of ACL re-injury informs some of the stuff that we've been doing all along in our data collection. And again, using biomechanics to measure this. But I do want to just focus in on one thing, and that is that how this study was conducted. You can imagine you have your injury, time goes on, you do a series of measurements. They actually use the measurements at about 9 months post-surgery. And then they use that data to inform the future risk of an ACL re-injury. And on average, ACL re-injuries are happening up to 2 years after that index surgery. So again, I just want you to think about this in terms of the complexity of the matter. This idea that you have a testing time point at 9 months and that's your anchor point to sort of safeguard this athlete as they make their return to a high-risk environment where the likelihood of them suffering a re-injury is actually a couple of years down the road, starts to sort of paint a picture of maybe a need to rethink this problem. And what I'd like to just sort of quickly touch on as we're making the pivot here in the presentation is to say, this is where treating re-injury just like we would the weather, which is having measurements that are taken routinely over time and using expert opinion, i.e. your weather forecaster, and data to merge those two together to be able to create, let's just say, better models of recovery and ones that sort of capture the potential that an athlete could be progressing well from 9 months, or potentially they could be regressing over time, is something that we're examining quite closely in our research program. So rather than that simplistic map, here's how this map actually might work. Look, in terms of all the web of factors that could go into truly getting back to sport, getting back to competition, and then monitoring an athlete sufficiently over time to look at potentially progression and regression in neuromuscular capacities to address this issue of ACL re-injury. So what we've proposed is to take a lens just like we would with our elite athletes. And here what we're talking about is to take a long-term performance lens where we embed biomechanical testing into the daily training environment of athletes. And we are able to obtain serial measurements over time and use these data to start to generate these more data-informed models of recovery. And so that's the transition point now that we're going to make in the presentation to talk about how we've applied this idea of monitoring the athlete versus this 9 months, you high five, you pass the final exam, you're cleared for sport, and away you go. We're trying to apply this idea of really tracking them over time and using a more expansive data testing approach to be able to mitigate this issue of ACL re-injury prevention. So the third stopping point in the presentation here is to talk about how we're doing this. And I want to focus on one test in specific and one capacity, which builds off the work that I shared from Enda King, which is this idea of assessing what we call stretch shortened cycle capacity. So stretch shortened cycle capacity is this idea that in human movement, many of our movements are these coupled eccentric concentric muscle actions. So we are stretching our muscles and tendons, and then they are shortening and doing positive work in these coupled movements, which might occur in sprinting, in change of direction movements, and certainly in jumping. And so the vertical jump, which is the standardized and repeatable test, and a set of force plates to evaluate the biomechanics or the kinetics of the jumping human, has become kind of like a cornerstone test that has now emerged in the space of secondary ACL injury prevention efforts. And there's a multitude of studies, and it's not only around rehab, it's also around monitoring performance fatigability, looking at adaptations to training. This technique is even used to study how our neuromuscular function changes with age. And you might be surprised to know that in some studies, they've actually had individuals in their 80s and 90s jumping on force plates and assessing them in the exact same way I'm going to present here to look at changes that might occur across the lifespan. But what I want to focus on for the remainder of the presentation is this counter movement jump technique. So the counter movement jump is shown here on the right. The hands are placed firmly on the hips. We encourage the athletes, give them strong verbal encouragement to jump as high as they can. They are allowed to freely choose their descent in the jump. So we don't constrain the movement strategy. We only say that you must keep your hands on your hips. And then the goal is to jump as high as you can. In this test, there is an unloading phase. So this is the phase of movement where you're lowering your body center of mass. There's a phase, what we call the eccentric deceleration phase, where you're effectively reversing your downward acceleration towards the earth. And then you have your propulsive phase where you're coming up and off the plates. And what's really nice about this technique and a set of force plates is that we can move beyond just how high did you jump, and we can actually break down the biomechanics to look at how did you jump and how did you achieve the outcome of your jump height. The other thing that's really nice about this is that in a training setting, we will address, let's just say, concentric strength capacities and eccentric strength capacities with different types of training and exercise. So how we would train our muscles for eccentric strength would be different than how we would train our muscles for concentric strength. And taken together, this test is a nice test because now we can look at this coupled movement and we can actually use this to develop more targeted training interventions for athletes who are coming back after injury. So I just want to highlight as we move through the presentation, a study that was we published in 2015, where we used this technique, a counter movement jump, and we evaluated lower limb mechanical muscle function in alpine ski racers who were all back to sport and back to competition. So these are athletes who are on average 2 years after their ACL reconstruction surgery, and we compared them to non-injured controls. And we did this to look at whether or not we would find persistent neuromuscular deficits that were there despite the fact that the athlete had reached, I guess on paper, the end goal. You're back to competition. You're back to doing what you love. And what was interesting about this study, as you're going to see, is we deployed this dual force plate system. And we also looked at these the kinetics of jumping, and we looked at it in relationship to muscle mass, which we measured in DEXA scanning, which I'll show you that data in a second. So briefly, kind of the full neuromuscular testing protocols, because the counter movement jumping is just one piece of the puzzle. We're also doing what's called a squat jump test, where there's actually no counter movement. So it's like a frog jumping. You squat down to a static start position and you literally jump like a frog would off a lily pad with no preload. We use an 80-second repeated squat jump test, hamstring and quadriceps strength testing. We do a functional force velocity test where we have athletes hold a bar and we load them up and we have them jump on the plates. And we also look at their isometric leg press strength. So the counter movement jump is just one piece of the puzzle, but that's where I'm going to focus the majority of my efforts here in the next 20 minutes of the presentation. So in addition to this baseline testing, the other thing that's really fun about a counter movement jump test and a force plate is we can actually run athletes through the test relatively quickly. So we actually conduct, in addition to this baseline testing, is we are running counter movement jump testing 1 to 2 times per week. So when you're training just naturally in your environment, you're coming in on Monday morning, you do your warm up, you do your jumps, and then you go and train. But we're able to collect this data in a more, let's just say, embedded way in the daily training environment. Think about where wearable technology is. And this is not a wearable technology, but the technology is right in the training environment. So it's like a living lab approach to testing. Just in terms of the counter movement jump protocol, 5 to 10 jumps on this dual force plate system. We are using AMTI force plates, sampling at 1500 Hertz. And we export this data and analyze it in custom built scripts. And we look at not only your jump height, which is kind of your classic jump measure, but we look at a whole suite of biomechanical measures that we derive from the kinetics of the jumping athlete. And we also compare the left side and the right side using the kinetic impulse, or the area underneath the force time curve. Just briefly about the technique. So we define our jump phases in a counter movement jump off the velocity of the body center of mass. So we go from force, we solve for acceleration, we integrate acceleration with respect to time to obtain a velocity of the body center of mass graph, and then we use that to define our jump phases, which I'm showing here on the right-hand side of the panel, where the light gray is defined as the unloading phase, the medium shade of blue here is defined as the eccentric deceleration phase, and then the concentric phase is shown here in dark gray. And the impulse, just for those who don't have wouldn't know the biomechanics of it, is we're literally looking at the area underneath that curve over those various time intervals. And here's why we do this. What we've observed is that in jumping, it's not uncommon for athletes with ACL injury to actually have asymmetries that depend on the jump phase. So you unload and you see an asymmetry that goes one direction, and then you put on the brakes, so to speak, in your eccentric deceleration phase, and you see the asymmetry go the other way. And then they're in the propulsive phase, and then the asymmetry goes back to the other side. So it's like this changing asymmetry over the jump movement. And this phase-specific approach to looking at asymmetries really allows us to see in these discrete movement phases which limb is more dominant. And that's been the approach that we've taken here in our research since more or less day one. A couple representative curves here where you can actually see the fact that the asymmetry depends on the phase of movement. The squat jump here is a nice example where early in the phase, jumping phase, it's actually the ACLR limb that's more dominant, whereas later in the jump phase, it's actually what you would expect. It's the contralateral limb that's more dominant in terms of the amount of impulse. So we calculate a really simple asymmetry index. You'll note that we maintain the directionality of the asymmetry by looking at the positive and negative number. A positive number means that the contralateral limb was more dominant. A negative number means that the ACLR limb was more dominant. And we do this in such a way that we can say that, you know, someone who's around 0% is using, like I would say on average, they're symmetrical. Because remember, we're doing multiple jumps here. So we're averaging this over 5 to 10 jumps. A positive number would indicate that the non-injured limb is more dominant. A negative number would indicate that the ACLR limb is more dominant. This study was interesting. And I mean, take-home message just in the spirit of time is that despite being back to competition and using this technique, we found significant deficits in our ACL injured athletes, previously ACL injured athletes, despite getting back to competition. So despite being more than 2 years post-surgery, we're seeing pretty stark differences between the non-injured controls and the ACLR athletes. But I do want to highlight something here just as we move forward is that when we look at the data, and in red here, you're seeing the mean asymmetry indexes for the ACLR group compared to control. But as as we build this out and sort of move towards the final part of the presentation, I want to just talk about kind of quickly about the N=1 case study. And this is so important because while at a scientific level, we're also often analyzing the group. Really at a practitioner level, we're often really interested in the single person sitting across the table from us. And you may remember that athlete who went for the tumble and I said, oh, he's holding the contralateral knees, just suffered a contralateral knee injury. That's him shown in the red box. And I have permission to share this from him. And what's interesting to note is that out of the cohort, that was our our first battery of tests that we applied on the athletes to look at these sort of group comparisons. But it was really interesting to note that this athlete that suffered the re-injury, because there was one athlete that suffered a re-injury, and that was him in the post-study period. He was the single athlete with the highest levels of interlimb asymmetry of the cohort of ACL injured athletes. You'll notice that some ACL injured athletes look pretty good comparatively to the control group. So it really started to inform this idea that it's kind of like an N=1 level that we need to consider this. Just briefly, as I introduce some of the tests, which are going to be important as moving forward, I want to talk as well about the fact that emerging data suggests that not only should we be measuring the biomechanics, but also some of these relatively straightforward tests that we've known about for 30 years, like Quadriceps Strength on a Biodex. They're actually very useful tests for secondary ACL injury prevention, i.e., your quadriceps strength deficits are correlated with a risk for re-injury. And this was a very nice study that, very similar to the work by Enda King, actually showed in a prospective study design that many of the conventional tests that we typically look at, like the single leg hop for distance, were actually not predictive of ACL re-injury. And in fact, in this study, it was only quadriceps strength limb symmetry index and delaying return to sport until 9 months that actually were associated with a reduction in risk of ACL re-injury. And I just love this tweet that's going to come up here in a second by Mick Hughes, who's a physiotherapist, who based on this study said, quads are king. For every 1% increase in quads limb symmetry index patients can achieve before going back to sport, it results in a 3% reduction in the risk of a re-injury. And to me, this kind of summarizes this idea that these old tests that sort of have become out of fashion, maybe in a clinical environment, are actually quite useful. And so I'm sharing this with you because another study that we did that will become relevant towards the end of the presentation is how we're looking at assessing quadricep and hamstring strength. So we do this on a dynamometer. We do this on an old Cybex where we've retrofitted it with a load cell that can sample at a high frequency. Not only are we looking at the maximum torque that's generated in the contraction, but we're also looking at something called the rate of torque development, which is how fast torque is generated in the maximum voluntary contraction. And the reason that we're doing this is these ACL injury events are happening in relatively short time frames, on the order of, let's just say 50 to 90 milliseconds. And so the current thinking in the literature is that by looking at how fast an individual can generate torque, we can actually assess the capacity for rapid force production, which has been sort of put forward as an important marker around not only returning to sport performance, but potentially around ACL re-injury prevention. So just quickly, because this will be relevant in a few slides, we've got this measure of max torque, so strength from our isometric maximum voluntary contraction. And we've got this measure of rate of torque development, which is we calculate here by looking at the derivative of the torque time curve. We find the max rate of torque development, and then we take a little window around that point to create an average, which is the way that we can get the most stable measurement, the best reliability for our tests. So another study that we looked at where we evaluated these skiers who are back to competition, now more than 2 years post-surgery, they're back. And again, the story was very consistent with what the data I just previously shared, which was despite getting back to competition, and despite being on average, more than 2 years post-surgery, right where the window is the highest risk for an ACL re-injury, what we found was substantial deficits in hamstring and quadriceps strength in our ACL reconstructed group compared to our non-injured skiers and also compared to the contralateral limb. But here's where things get interesting. If you break it down again to the n=1 level, you see a whole mixed bag that basically results in these bar plots with the standard deviation bar. What we see are some athletes that are looking like they're faring pretty well. They've got 2 strong limbs and they're relatively symmetrical in terms of their strength. We have some athletes with really dramatic asymmetries, but they're relatively strong. And we had athletes that were both asymmetrical and had 2 weak limbs. And so this comes down to this idea of inside this group, while we may have some athletes that look pretty good, some athletes are definitely lagging behind where they should be. And so as we pivot in this point in the presentation, I just want to say that ACL injury may unfold differently between athletes. The progression towards or away from the benchmarks of recovery can change over time. And obviously, there are all kinds of other factors that come into play here with managing an athlete who suffered an ACL injury at that n=1 level. And I'll give you one final example here of a case study that we published in 2020, where we looked at an elite alpine ski racer. We had almost 10 years of data from this athlete, all of her training loads and testing data, performance data, and we were able to track her over her career to the point where she suffered her ACL injury. And then we looked at her recovery through that injury back to 18 months post-surgery when she was back to sport and back to competition. And why this case study was so compelling is, and I'm showing you here two figures, panel A, panel B, both are showing hamstring and quadricep strength measures. The maximum strength measures are shown on panel A. The explosive strength measures are shown on panel B. So that's how fast she made torque. And what we have here is the time course. So basically from early on after her ACL reconstruction surgery up to 18 months post-surgery. And I want you to take a look at this. So first of all, we're going to look at the ACLR limb. In black solid line, that's knee extension torque. The dashed line will be knee flexion torque. You'll notice that at the 18-month post-injury time period, there's a relatively robust increase in her ACLR limb knee extension torque, which is evidenced by this dot here where my cursor is. Interesting to note, while her maximum torque capacity, so this is strength, has made a relatively robust jump, you'll notice that her explosive strength, which is the ability to make force fast, which is different than maximal strength, is still relatively flat in terms of that post-injury recovery profile. She had a hamstring tendon autograft, so you'll notice that there is sort of a marginal increase in knee flexor torque over the recovery period, which we've shown in other studies consequent to that hamstring tendon autograft. But here's where the really compelling piece of the puzzle comes in. This is her contralateral limb. And you may remember that I said that the risk of contralateral knee injury is actually has been shown to be higher than re-injuring the same side. And what's really compelling about this is the linear decrease in not only her quadriceps strength, but also her quadricep explosive strength over that post-injury recovery period. So this is a great example of flagging a contralateral limb strength loss after an ACL injury. So it's the opposite limb in this case that we need to be addressing with our training methods. So transition point is here. So what does this tell us? Sure, at a scientific level, we aggregate our data. We're looking at group trends, group data. But in the world of sport, it's often the data collected on the single athlete over time that is used most often for decision making. And so as we make this transition to our final stopping point in the presentation, the key point is that rehabilitation does unfold differently depending upon the individual, and it's not a linear change over time. We have to be looking for deficits, and we have to be taking a sort of a long-term monitoring approach to the problem. And this is I take this from Dr. Nate because I remember him saying this to me at a conference once. I've paraphrased it a little bit, is that if we aren't testing, he said measuring, we're probably guessing. And if you're guessing most of the time when it comes to rehab, it's probably hard to train effectively. So this is at our transition point to say that, while our goal sure is prediction, and we'd love to know, genie in a bottle, who's going to be at risk here for a future ACL re-injury, what we are really interested in is finding these trainable deficits that we can target in on with our training methods to be able to mitigate and hopefully send a more physically prepared athlete back to a high-risk environment. Okay, final stopping point. I want to talk about how we are moving from case study to prospective study, which is now using this idea of our expansive neuromuscular testing, aggregating this data over time, and now using this in statistical models that can help us make, let's just say, N=1 decisions for the athletes that are coming through the R2P code program. Some of the data that I'm going to show here is using what's called a generalized additive model. And I want to just kind of quickly preface it that this is the statistical model that we're using to make these forecast recovery profiles. And how it's been explained to me, and I don't profess to be a statistician, but I did consult with a statistician on this project, is that generalized additive modeling sort of sits in between our conventional linear regression models and machine learning, i.e. it's an additive model, just like a linear regression where you have predictor variables that are built into the model. But the generalized additive model allows us to account for nonlinearities in our data and complexity in the data. So we can fit smooth terms that allow us to fit our data more effectively for the types of scenarios that we might be working in. And simply put, what we're doing is collecting all this data and using this data to be able to generate these models using this approach. So just kind of, I'm not going to get into the nitty gritty of how we do this, but these data were prepped in a package called, or a program called R, using what's called the MGCV package. We did this in consultation with Dr. Isabella Gament, who's a statistician, and we built these models that allowed us to use various predictor variables using smooth terms so that we could generate some models of functional recovery. And in this case, what we were really interested in was how does recovery change depending upon time from surgery and depending upon graft type. So whether you got a bone patellar tendon bone graft or a hamstring autograft. Our database now looks like this. 10 years of testing, right, that we used in this particular study. So we had about 3,200 tests from our non-injured controls, almost 600 tests from the ACL-R injured group. In this case, we used our counter movement jump test and our knee extensor strength tests into the model. In terms of sample size, 196 non-injured controls, 18 athletes with pre-injury data. Our ACL-R athletes at the time, we had 34 of them in the study. And we're looking at the number of measurements per athlete, somewhere around 19 was the average for the control group and the ACL-R group. And we were able to obtain these data and these measurements from about 2 months post-surgery to 24 months post-surgery. Just to show you what the raw data looks like, this is our non-injured control group showing the asymmetry index on the vertical axis, calculated the way I described previously. And then looking at our hamstring tendon autograft and our bone patellar tendon bone group, looking at at various phases after ACL reconstructive surgery, looking at how asymmetries are changing in the counter movement jump test and the knee extensor strength tests. And just to mention here we've aggregated the eccentric deceleration phase asymmetry, the concentric phase asymmetry, and the 2 quadriceps strength measures that I showed on the previous phase of the presentation. Now looking at some of the data, and this is where an example of how we're applying this, the additive mixed effects modeling. And what we're actually showing is that, depending upon graft type, we actually see very different recovery profiles. So here what we're depicting in blue is the recovery of interlimb asymmetry for the bone patellar tendon bone group, and that's shown here in the kind of the greenish color, and the recovery in asymmetry for the hamstring tendon group. So what you can see is, again, remember all the measures are kind of aggregated into this asymmetry index, is that our models are showing that it takes about 300 days for the hamstring tendon group to look like a non-injured control, which is what these dashed lines are representing. Whereas for our bone patellar tendon bone group, we're looking at about 400 days when it comes to our jump asymmetries, which are shown on these two panels. However, if we take a look at quadriceps strength, and this is starting to become sort of a well-known and accepted observation in the literature, is that your biomechanical asymmetries really do seem to depend on graft type. And so here what we're showing is that your strength asymmetries, we're looking at nearly 400 days for strength asymmetry in our quadriceps strength to recover after a bone patellar tendon bone autograft. Whereas with the hamstring tendon group, you'll notice that within sort of a very short period after ACL injury, they're actually already starting to trend back towards the level of our non-injured controls. So for example, this has been sort of some of the driving data around why do we choose a hamstring tendon autograft for an alpine ski racer? Well, because of the demands of ski racing on the knee extensors overall and the patellar tendon. These have been sort of some of the I guess you could say it, conventional wisdom from our surgeons on why they choose that. But this data is now sort of helping us to see how this may depend on sort of a larger scale environment with many athletes now in our database. We can actually model this more effectively. So just as we transition, I want to show one final thing in just a couple minutes. I realize I'm right up on time, but I do want to share one final piece. And I just want to say that, similar to the weather, what we're trying to do is combine expertise of the people in the environment with data to forecast recovery. We're doing this again, holy grail, I'd love to predict injury, but also answering simple questions like, when do you expect me to be ready to get back to sport? And to this end, what we can use is this type of testing to identify a neuromuscular capacity that may be lagging behind another one over time. And I think that this is important because what it allows us to do is to account for some of the things in the ACL recovery process, which might be, let's just say, dependent, right? It might be sort of dependent on, things like your training history, the type of surgical procedure that you had, the type of injury you had. And the goal would be able to put this into a model where we can start to say, here's what the average athlete looks like, and here's the trajectory of the athlete that's in front of us. And again, importantly, while we do this sort of at a large scientific level to understand bigger questions, very often these data become important at the N=1 level for our athletes. Okay, quick final stopping point that I want to just touch on is to look at a second study that we just published, where we looked at female elite alpine ski racers. And we evaluated 30 non-injured skiers, 6 with pre-injury data who ended up going on to suffer an ACL injury. And we had 17 athletes with an ACL reconstruction surgery in the cohort. The non-injured athletes were evaluated over a 16-year time period. And our ACLR group was evaluated over a 5-year post-injury recovery period after their ACL reconstruction surgery. And we were looking at here a total of about almost 600 counter movement jump tests. These are some of the mechanical measures that we obtain from our jumping athlete, looking at peak external mechanical power, their jump height, their reactive strength index, lower limb stiffness, and some measures of their eccentric strength capacity. Really briefly, just want to show how we derive these measures. So we go from force, we look at the velocity of the body center of mass. As you know, we look at impulse over these specific phases, where we look at not only the impulse for both limbs, but we compare the left limb to the right limb, as you've seen. We're looking at the individual's takeoff velocity. We're looking at the individual's maximum velocity. We are taking in a measure what we call the reactive strength index, which has been a way that has been used to quantify jumping capacity. by looking at a ratio of flight time to jump contraction time, the external peak mechanical power, which is derived from the vertical ground reaction force and the velocity of the body center of mass. And then very similar to the work of Enda King, we're looking at this measure that we call lower limb stiffness, which is essentially a measure where we plot the force of the ground reaction force against the displacement of the body center of mass. And we're able to get these work loops, and we can actually look at the stiffness of the system, so to speak. Again, I'm not talking material stiffness, but sort of how they're executing the jump. And we're doing this in such a way that we're able to quantify a really important jump strategy variable. Now, final take-home message is this. Remember in the last slide, a couple slides ago, I showed some asymmetry recovery profiles. And I showed that it took about, seemed like, about 300 to 400 days for athletes to sort of recover their interlimb asymmetry. But you also may remember that I said that we see instances where athletes actually lose contralateral limb strength over that post-injury recovery period. So in this case, in this study, the data was quite consistent. It took about just a little over 2 years for the interlimb asymmetries to minimize to the point of the non-injured controls. But when we looked at absolute stretch shortened cycle capacity, so here what we did is we looked at this relative to the benchmarks of skiers who were more than 25 years of age. What we found was despite 5 years post-surgery, many of these markers were actually still lower than the values of our non-injured control group. And so as I just sort of wind this down, this has led us to this idea that user beware of the between limb asymmetry index, and that at the very least, if you're going to compare a right limb to left limb in an injured athlete, we know that because of all kinds of factors that non-injured limb is also susceptible to losing strength. That at the very least, if you're using an asymmetry index, that it's important to actually also look at the absolute capacity of each limb and potentially the whole body in the athlete as they recover. So with that, I just want to wrap up. We hopefully was able to create a picture here of our research program and talk about this issue of ACL re-injury prevention in ski racers. And hopefully show in a sport population, in sort of a living lab approach, how we're moving from the N=1 level back up to sort of a prospective study, informing this long-term, decade-long study now, but then really using these data to answer important questions that really do matter for athletes who are coming back after ACL injury. So for future directions, we're going to continue to work on our database of obviously growing this over time. We're looking at developing new tests along the way here to pinpoint trainable deficits, looking at new tests to measure stretch, shortened cycle capacity, exploring the impact of training, injury, and detraining on neuromuscular function and muscle proteins, linking the continuum. So this is work that I'm excited to be doing with Dr. Passanen, where her focus being on primary ACL injury prevention and other sports too, so soccer and basketball, and then our work where we pick up athletes after injury, sort of taking this into a whole continuum, and then ultimately translating this work from high performance sport, kind of like an incubator for ideas, where we can bring this now to a community level, especially downstairs in the sport medicine clinic. We're excited to be able to start to take some of our concepts that we use in elite sport and apply them in that setting. So with that, I just want to wrap up. Sorry for going a couple minutes late. And thank you very much for your attention.
Thank you, Matt. That was a great presentation. And at this time, I kindly ask the audience members, if you're comfortable, to please turn on your Zoom camera to allow for a better discussion. To ask a question, you can use the raise hand function on Zoom or type your question in the chat box and I will read it aloud. So maybe I'll start with a question, Matt. So at the start of your talk, you looked at visual inspection of frontal plane kinematics. And then when you showed the King study, that was moving towards sagittal plane biomechanics. And then towards the end, you move towards ground reaction forces, which are sort of center of mass mechanics. And where should we be looking? Which of these kind of areas is the most promising trainable deficit? What are your thoughts on that?
Yeah, I think the literature today is pointing to number one, and I'm speaking specifically about the ACL injury context, but using vertical jumping as opposed to horizontal jumping. One thing that's been, I mean, practitioners tend to know this, but I would say the science is catching up as well, is that a horizontal jump really lets you engage the hip and ankle more. And so if an athlete is masking a quadriceps strength deficit, which is what we might expect after an ACL injury, they can hide it pretty well with those horizontal jump tests. And so I think the first part of the answer to your question is to incorporate vertical jump testing. I think that the second part of it is the kinetics seems to be a crucial component of it for being able to look at deficits in the ACL injured athlete. And certainly the biomechanical testing is another layer. Now, we're not currently doing that because it is relatively time consuming for the type of environment that we're in. But Enda's work, that data that I shared, the biomechanical testing was actually also an important marker. So how they are changing direction, how they are performing the task. But the eye, just sort of the visual inspection, I just think, the data wouldn't support that.
Great. Thanks. Brent, please go ahead.
Thanks, Matt. So for me, when it comes to ACL injury, both primary and secondary, especially in alpine skiing, it's like this big regression problem, and you have these beta terms, which is like the strength of the person's knee and the size and elasticity of their ACL, okay? And then there's this big error term that you'll never ever to be able to explain. Like never, right? Because of the uncertainty in what happens in a downhill ski race. How big is that error term in your, like, can you, and I'm not asking you to speculate like if you can prevent 50% of ACL injuries or minimize the risk or whatever by 50%, but how much do you think is preventable or predictable, and then how much is left over that you'll just never be able to predict?
Yeah, I mean, Brent, I was having a chat with Nathan Boone, who's one of our graduate students, just before this talk, and sort of discussing this, right? This issue, which I would argue it's what you're kind of alluding to here, Brent, is it's a complex system, and it's and there are many factors. We were talking earlier about psychology. So what if you and I both have an ACL injury, and I'm scared to death, and you're not? You're fearless, and you're going to be potentially taking more risk, but you're more confident. What about exposure? Like if you're, there's all kinds of things here that I think I would argue are challenging. But if I put my ladder against a different tree, the ladder would be to say, I know you've had an injury, and I have a picture of what you looked like before, and I'm going to try to address your physical and mental preparation to get you as physically prepared as possible for returning to a harsh environment. And so to that end, I would say that there's no question the error term in that world of injury prediction, I think, is going to be injury and re-injury prediction is going to be really challenging. But to me, the fundamental idea that we're going to use training and exercise to mitigate neuromuscular deficits that have happened because of this injury, and we're going to use objective testing to inform our decision-making, is a relatively simple concept. The question will be, as we collect more data, will we ever get to a place where the sort of genie in the bottle prediction, approach could actually provide some utility? And I don't know the answer to that.
And do you think that there's more success to be had in secondary prevention than in primary prevention?
I mean, I think, Brent, like I almost feel, even just as what I was just wrapping up that thought, that I'm underselling it a little bit. I really do think that these strength and neuromuscular deficits that we identify before injury and after injury are fundamentally connected to a risk of injury. And I don't want to get too far ahead of myself here, but there's some great data coming from Jörg Spory in Switzerland, where they've done, looking at hamstring muscle architecture in youth skiers and assessing, very similar to the types of things I'm discussing here, but like basic biomechanical muscular characteristics, and in a controlled environment, looking at occurrences of injury. And what they're finding is that there are associations between these things, and these things are trainable. And I would just say that maybe this speaks to the work at the Sport Injury Prevention Research Center, but injury prevention training programs do appear to be useful in mitigating risk of injury. I personally think that both are good things to pursue.
I was going to ask one more question, but I'll let Rob.
Go ahead, Rob.
Matt, I was really impressed with your talk, and I enjoyed it. But unfortunately, I'm going to ask you a question that's not hard on the biomechanics. You had a cartoon of someone in their skiing in their long red underwear, and it showed them coming down and landing with the back of the ski on the ground, and then you had this massive lever arm that you'd imposed on the effectively on the knee to slap it forward, and got that rapid change. And let me say first of all also that I'm not a skier, so what I'm going to say is going to offend most of the audience here, I know, but we currently have an external skeleton on the ankle, and we call it the boot. And everyone just accepts it. Here we go, we've got this external skeleton, it protects the ankle and makes it happen. But what about if you step back a little bit to prevent this injury, if you added a gentle external skeleton to the knee that was there to give a viscous element? Because it was a perfect little cartoon, because it just showed, it just looked ridiculous. This massive lever arm to slap the knee forward. So if you had a viscous element that you wrapped around the knee to protect it from those fast movements, then, if we can do it on the ankle, surely we can do it on the knee. And the reason I'm swayed a bit, because the American Olympic alpine team, 100% of them have had knee surgery, and the Canadian team it's in the 90%. So maybe there's a young one who hasn't had the knee injury yet. But why would we think we've got the perfect ski system? Why not just say, if this is so incredibly dangerous, and that cartoon just exemplified it, what would you think of a viscous element on the knee in an external knee skeleton?
Yeah, I mean, I think it's a great question, and I know one of the last conferences that I was at before the pandemic was the International Conference on Skiing, which was in Austria, and there were a multitude of presentations on this exact idea. And the one thing that came up, although I think maybe in the context that we're talking here, there might be other solutions, but the one concern that got brought up in the crowd, I remember a question being asked about it that I thought was actually quite interesting, was, is there any sort of risk of a plastic on the knee or something like that could potentially either fracture or splinter in a fall, where maybe now you got something impaling your femoral artery, and or reducing the athlete's natural sort of neuromuscular control. I mean, I'm going to say this in loosely, but like putting a pair of boots on a cat's feet, right? Like you remove their proprioceptive ability and the cat can't walk. with an elite athlete, it's, it's not that different, although they may not look as funny, but obviously it's a highly tuned machine. I think that was the debate, but the idea of protective equipment seems to be still at the forefront. And I think that's a great suggestion. That was the only concern that anyone could think of that might be a problem. But I think we come back to that as being a good, maybe an area for future research.
Because you could have the viscous element come in late in the stage. So for most of it, just design the element so that it was for normal movements. You don't even know it's there.
Right.
It's only on the fast elements. It
Right.
slaps up high there.
Yeah.
And we do carry 2 spears with us if we're going to crash. So we are carrying some dangerous stuff.
Yeah.
Well, I say we, but not me.
Yeah, nor not me either. But I was going to say just to maybe address one more quick little point is that you're absolutely right that the injury mechanisms are quite, they are distinct in skiing. There are 4 identified injury mechanisms, which are quite different than field sports. And so when you watch a soccer player or an American football player make a cut and a change of direction, and then they buckle and they go down, it's truly a non-contact injury. I mean, it is something to do with their neuromuscular system, maybe the interaction of the foot with the turf, and in an instant, that ACL ruptures. And then you look at ski racing and you've got, like, to your point, a plastic boot, a big ski, and this thing is acting like, torquing and twist. I mean, that leads to the question to say, can you prevent these things? Mm-hmm. And I will just say that my last little comment is that there is that setting with elite athletes, but it seems as well when we look at the development level, so adolescent skiers, we also start to see the emergence of these non-contact injuries. So you go off an innocuous jump and you land and boom, both ACLs rupture, one ACL ruptures. So I think context is quite important here. And what might be a good solution for the adolescent skier might not be the solution for the elite skier, given the environments that they're in.
Yeah. Thanks, Matt.
Other questions from the audience? Benno, please go ahead.
Yeah, when you talked about these football players, I was once in a court case where one football player had ruptured in one situation his left ACL, and in the other situation his right ACL. And we had, at this situation, we had videos from the accident. And then you can make certain assumptions where the forces would act, because the person would land in a position with the body weight in the back. Anyway, I played around and I could never, ever create a situation with the forces that I assumed that would allow the ACL to rupture, except if I assumed that at one point in time, all the other forces were zero. That was the only possibility that I could explain that the ACL would rupture. Now, wouldn't that mean that it may well be that some of these ACL injuries may not depend on actual big forces that act on a system where everything is active, but that it could be that these injuries could also occur when you see something, and because you see something, you're scared and you turn everything off, and that makes the forces in the ACL much more and make a rupture. What do you think about that?
Oh, I think that's a very not only is it a a very realistic mechanical observation or insight, but it seems like in studies where they've looked at neuromuscular control strategies, so measuring the quadriceps and the hamstrings and measuring how the muscles are working, that there seems to be some evidence that neuromuscular control strategies may differ between groups that go on to suffer ACL injury and not, to the idea that maybe some muscles are not working quite as well or quite as much as they should in that pre-injury period. And, you know, sometimes when I'm teaching about this, I'll talk about the idea of, you know, you're walking down a flight of stairs and the lights are off and you forget that there's a step, and then you hit the ground and your body's not prepared for it because you have no pre-activity. And we all know what that feels like, is that you hit the ground and all bets are off. You stumble. And in a very similar way, I think that these neuromuscular control strategies and also how the muscles are working together to be able to create a protected system. And importantly, the fact that I've seen lots of other cadaver-based studies where with muscles, I mean, the dynamics of the joint really change, which really leads you to say, is this more of a neuromuscular error? As in something's happened, whether it's perceiving information, concussion, you know, there's been a lot of sort of centrally mediated injuries that you know seem to be associated with another, like a future risk of a lower body injury, like an ACL rupture. Is there something happening with how, like, much more depth in terms of sensory motor coupling? And I think that's a really critical place to look.
But nobody works on that.
I've seen some studies, but most of them are limited because what they'll do is they'll bring a group of athletes into a lab, and they'll put on EMG electrodes and measure kinematics and kinetics of, let's say, change of direction movements over, let's say, 4 or 5 changes. And then they'll look at the neuromuscular control strategy, and then they will follow the athletes over time down the road to see who gets hurt and who doesn't. And I think that like those sorts of studies have been done, but my criticism there would be is that how representative is that measurement that's taken at that single point in time in a lab environment to what might happen, you know, 3 months down the road in the observation period when somebody gets hurt. And so I think maybe there's got to be a way to from a technology perspective to be able to get measurements in the real world to answer these questions more effectively.
Great. Art, please go ahead.
Hi, I was curious about what causes these strength asymmetries. I guess I would have assumed that usually it would be the ipsilateral limb that would be the weaker one, because you have a strong limb and maybe you cheat during your rehab, and you know, if you're doing leg extensions, you can cheat and prefer to use the stronger limb. But it's hard for me to think of how the contralateral limb would end up weak in some cases, unless maybe people are sort of expressly exercising the ipsilateral limb. Maybe they're doing single leg exercises and then neglecting the other limb. So I'm just wondering, do you have a story for how that happens? Either direction of asymmetry.
Yeah, pure speculation here, because you know, I don't know that there's enough data there to answer this like with a level of conviction. So if you'll permit me there, so for example, I mentioned we do this 80-second repeated squat jump test. So it's again done on force plates, one jump every 4 seconds for 80 seconds, but the athletes jump from this static position. So it's pretty hard. By the end of it, they have some acute neuromuscular fatigue factors present. And it's quite interesting to note that at certain phases, as we start to do this test in the return to sport process, we'll start to see that they are loading their non-injured limb more. And because they're loading their non-injured limb more, it actually fatigues faster. And I'm saying fatigue in a bit of scare quotes. Let me be very specific. The impulse, the fraction of the vertical ground reaction force that's being sort of contributed by the right and the left, that the injured side is decreasing over the jump test. So it's a sign that, like, you know, the force generating capacity of the injured side, of the non-injured side, is actually diminishing. So they become more symmetrical with fatigue. And one of the things that we've speculated on is that maybe there are fatigue factors, is in you're on the field of play, you're loading these asymmetries, and you're actually creating a maladaptation in that process that could be at play. Now, that wouldn't explain why you have so much detraining in the contralateral limb, but it might explain in an acute setting where maybe an injury is happening out of the blue, and you're ending up hurting the other limb in the final half of the soccer game, so to speak. I think the other thing that I would say, and this is where I hope maybe some of the work can go, is that it seems like the ACL injury is affecting the brain, as you would imagine. So, you know, motor centers, how you move, how you're, you know, all of those things. It's not. It's pretty clear there are these changes happening, and I guess the question would be, how are those changes potentially leading to a detraining of the contralateral limb from sort of a central perspective, and what might be happening at the muscle level? And I don't have a good answer for that. I mean, it's certainly the case that, you know, we sort of view it now as having, the most important thing is having two strong limbs. And if you can have two strong and symmetrical limbs, that's great. You know, you don't want to have two weak but symmetrical limbs. That seems problematic. And so, you know, to this end, the mechanisms that explain, like, why is that happening? I don't know what they are. The one thing I will say is that the obvious thing would be that you're in rehab and you're just using the other side more, which I think is probably fair at some points. You know, but as the athletes go on and train, they don't, you know, at the time points where we're measuring, in that case, it was 18 months post-surgery, that athlete just come off a ski season. She'd been training, she'd been lifting, training both legs, you know, doing her exercise. Like, she's not doing once, like, just normal exercise like we all would do, skiing normally, right? So I feel like it might be a more complicated answer, and I don't know for sure what it is.
So the videos you showed of the person jumping, was that in the training facility?
Yes. Yeah.
Well, I wonder if it would be possible. Well, so I gather from that you have dual force plates in a place where people do jumping and squats, and I just wondering if you can just collect data on every single squat and every single jump they do during rehab, and then just see are they cheating or doing something preferential either direction, and then how does that change as they progress?
Yeah, no, it's a great idea, and you know, it's quite interesting. And this is again anecdotal, but you know, if you're missing 25% horsepower in your left knee because you've had a knee injury, and your goal is to maximize a jump height or maximize how much weight you're going to lift in a squat rack, very similar to as if a bear ran down the hall in the HPL and I've got a bummed knee, I'm not going to move to sort of have high movement quality. I'm going to move to not be the last person out of the building, and I'm going to move however I need to get my butt out the door. And very often what we'll see with athletes is when we're retraining, like when they're in this retraining and reconditioning process, is they're training to maximize things like how much weight's on the bar, how high am I jumping? And they'll use a movement strategy, which actually exacerbates the issue. So they'll work around the weak knee. And so I come back to that idea. It's like, if you know, it's sort of like an internal constraint has changed. You now have 25% less horsepower at the knee joint. So what movement strategy do you employ to now maximize your sport performance? And does that lead to this sort of repetitive training, like you're suggesting, this repetitive training movement pattern that actually leads to this stuff down the road, which we now measure as like a contralateral loss of strength or you know, yeah. And I think it's a great idea. Yeah, it's a great idea.
Great.
I might just do that.
Yeah, sounds great.
Yeah.
Great. I think with that, well, please join me in thanking Matt for his presentation today, and thank you to all the audience members for their questions. I hope to see everyone again for next week's HPL seminar.
Thanks, Emily.
Thanks, Matt.